interpreter.
So yeah, Matt needs an interpreter on. Okay, great. Hello, welcome.
Okay, thank you all for joining this conference. This is a telehealth session. We have both individuals on the panel. Myself, I am Matt Myrick with the TDI member at large. I've been with TDI since 2016. And on this panel, let me self-identify for those that we have participants on the audience that are deafblind. I have brown hair, wear glasses. I'm wearing a blue polo shirt. I have a TDI logo on my left chest. Next, I would like to hand it off to Lisa.
All right, hello everyone. I am Lisa Bothwell. I am a Caucasian woman in my 30s. I have short hair. I'm wearing a black shirt with a black jacket, business casual. I work as a manager for Community Life, ACL. And the goal of and mission of ACL is to support people with disability and elderly adults living in their homes and in their communities. So my area of expertise is policy-related review. So we review different policies and do development within those fields. So with that, I'll turn it over to the next person. Mai.
Hello, I'm Kwong. I'm with the Center for Connected Health Policy.
So sorry, we need the interpreter up.
And I'm Chinese. I have long dark hair. I have on a blue dress with leaves on it and a pair of hoop earrings. And I wear glasses. I think I'm the only woman on this panel wearing glasses. And what the Center for Connected Health Policy does is that it looks at telehealth policy on the federal and the state level.
Suzy.
Hi, everyone. My name's Suzy Rosen Singleton. How to describe myself? I'm wearing a black jacket with a necklace. I've got my hair up. It's blonde. I'm in front of a blue background that is very plain. And I work at the Federal Communications Commission in the Consumer and Governmental Affairs Bureau in the Disability Rights Office. And I am the chief of the Disability Rights Office, focusing on video programming, modern communications, and emergency communications access for all three of those areas. And we collaborate with other bureaus in our agency on those. I am here today also to share some of my personal experiences and a wonderful success story for myself and telehealth access. So hoping to share that as well, but coordinate very closely with Lisa we work together in the Federal Interagency Accessible Telehealth Working Group to make forward progress in ensuring that DOJ, HHS, FCC, and all those agencies partner together to protect your rights to have accessible telehealth. And I'll pass it back to Mike, I guess.
All right, great. Thank you so much. My name is Mike McKee. So I'll identify myself. I'm a Hispanic and Caucasian, have brown, red, auburn hair. Currently, I'm in my home office and I have a blue and white striped shirt. And I'll explain a little bit about my role. I am a deaf family medical physician. I work at the University of Michigan in their Department of Family Medicine. I work as a physician there, and I'll talk about my experiences interacting with in-person and then now moving into a more of a virtual sphere. So I look into we do investigations into some of our clients and patients. So I'm looking forward to having that discussion with this panel.
Okay. All right, thank you. Okay, so let's wait for the interpreter to come back on. All right, thank you. And so let's go ahead and get right into the panel discussion. I know this has been a hot topic you know, with the pandemic that, you know, hit us last year, and there are lots of questions regarding to the telehealth issues and et cetera. So I would like to start with the very first question for Mai. Mai, can you provide a brief description of the telehealth and what exactly it is and how it's being used?
So telehealth really just means using technology to provide healthcare services when the patient and the provider who's providing the service aren't in the same location. So they use technology to bridge that distance. And the types of services that it's been used for vary from specialty to specialty. So you can have some services, some specialties which they can use telehealth a lot for a lot of their services, and then you have other specialties where maybe they have a narrower range of using the technology to provide those services. A lot of times it really is left to the provider's judgment on like when to use it in consultation with the patient, because you can have situations where you have two patients being treated for the same thing, but maybe technology isn't the best way to provide a service for one patient as it is for another. So even though I'm a telehealth proponent and advocate, even I say it's not appropriate for every single situation, but it should be available for anyone who may want to have those services provided via technology.
Thank you, Mike. This next question is for Lisa. And can you expand on the requirements for accessibility and for telehealth providers?
Sure. This is Lisa speaking. So I'll focus now on 3 points of three legal points, but they might have other applications, but I'll focus on 3 things. The ADA, which is the Americans with Disability Acts, Section 504, the Rehabilitation Act, and Section 1557 of Patient Protection and Affordability Care Act, which is the ACA. So many of you are already familiar with the Americans with Disabilities Act. There are 2 types. So type 2 typically covers state and local governments, which are public entities. And then tier 3, which would apply to places of business accommodations, professionals' office, healthcare provider offices, hospitals, social service centers, establishments, insurance offices, pharmacies, so forth. Section 504 applies to entities receiving federal funding assistance and also to executive agencies, federal agencies. Section 1557 applies to entities receiving federal funding, assistance, and entities which are covered by the ACA Title I, and that would typically be through the state-based, insurances through the state-based marketplace. So those 3 are the legal aspects we'll be talking about. And these are the things that the DOJ mentioned last year. In the context of healthcare, non-discrimination based on disability, meaning equal access to available healthcare services, regardless of if those services are provided in person or through a virtual platform. So an example of that would be telehealth or telemedicine. So telehealth, we abbreviate TH, and telemedicine, we abbreviate TM. So that would include effective communication and accessible information and communication technologies. Effective communication would mean the communication must be effective for people with disabilities on an equal level as its effectiveness for people without disabilities. An interesting thing about the effective communication, which includes accessible information and accessible technologies. And the definition of auxiliary aids and services. Let me back up just a second. Healthcare providers, they are responsible for providing auxiliary aids and services, which we call AAS. Typically, you might be familiar with interpreters, captioning services, a variety of alternate formats and so forth. So I just want to provide two resources. I'm trying to go ahead and wrap up, but I want to provide two resources that have been released that might be related to this audience, pertinent to this audience. So it's under, the ACA is under HHS. So under HHS is the Office for Civil Rights, the OCR. And the OCR has released two bulletins. One of those is regarding civil rights requirements during the pandemic, during COVID. So, and in the past, talk about accessible electronic information and technology. And I'll include those in the chat if anyone's interested in reading up more about those two documents. And I just want to take this moment to provide some information about how to file a complaint. There are two places that you can file a complaint. One is with the HHS Office of Civil Rights, the OCR, or through the Department of Justice, DOJ. The DOJ's Disability Rights Center. So I'll also include those two links for more information. I'll include that in the chat box. With that being said, I'll turn it back to Matt.
Okay, awesome. Thank you, Lisa. Can you elaborate? Now, this question is back for Lisa. Hold on a second. Interpret. Yeah, so again, Lisa, can you clarify what effective communication is and provide some example around effective communication?
So as I said before, effective communication is an entity, if they're under one of those three tiers or another civil rights law, and it has to ensure that communication with people with disabilities is as effective as it is with others without disabilities. So effective communication can mean that the care provider is responsible to provide those auxiliary aids and services, which can include interpreters, qualified interpreters. It can include captioning, CART, which is real-time captioning. It can include alternate formats, for example, Braille, other formats. And I think that's
Do you want me to add? May I add to that?
Yeah, Suzy.
Yeah, hi, this is Suzy speaking. Once upon a time, I was a litigator in California, and there was a case that I litigated against Aetna, a hospital that refused to provide interpreters for a spouse of a patient who was on life support and comatose, and they needed to disconnect life support, but they had said that because the spouse was not the patient, they refused to provide accommodations there. And I was at the California Center for Law and the Deaf at that time, but the ADA had just passed, this was in '91. But there were not regulations yet promulgated on that. So we ended up going to the Ninth Circuit Federal District Court to discuss what effective communication meant in the absence of regulations. And effective communication was published then to mean requiring interpreters for complex communication. So it really does depend on the communication itself, whether it's rote, or complex, whether it's significant or minor. There's a number of different factors that go into that determination, and writing back and forth could be considered in some contexts effective communication, but it depends on the specific details of that case and situation itself. It's a very complicated concept. So it is very individualized and fact-based depending on the environment as well. But basically, since the 1990s to today, the interpretation has been that effective communication requires that the individual with the disability feels that it is effective. So for example, if you were on a telehealth appointment and you would prefer an interpreter, then you should have that type of accommodation. As effective communication is very idiosyncratic and dependent on the individual's needs. So I just wanted to chime in there that certainly there's a whole suite of options that exist, but you ultimately have to ask the patient or the patient's family member in some events about what would be effective. So that can try to help clarify what effective communication, and with the lawyers working in a lot of these gray areas here, but trying to nail it down.
Yeah, thank you, Suzy. Thank you, Suzy. And it's not a one size fits all, category. So it's just really depending on, the communication modality. So it's very important. Okay, so moving on. This is a question for Dr. Mike. And why are telehealth platforms not accessible enough? And what features would make telehealth platform fully accessible for all? Can you share some insight on that, Mike? Dr. Mike?
Sure, thank you so much for the question. So the platform, there's a variety of platforms out there. For example, we have video, Zoom, a variety of different platforms available. Some of those platforms aren't accessible. It's more of for hospitals, doctors and institutions or systems. When they contract, maybe they were looking for the cheapest option, not the most advanced. So there are, when we have those platforms available, there are some limitations. So for example, for Zoom, you can have live captioning as a feature of Zoom, automated live captioning, or if you'd like to have three-way, meaning you have video, would be a simple call to a doctor on video. I can see the doctor can see me. Or if you'd like to add a third, like a three-way, meaning you would have a third video interpreter involved, and then they would have to be contracted in advance to have that available. So it's not a question of if the technology is or isn't available. It's that is the institution, the staff, the doctors, the healthcare system, do they know about, are they knowledgeable about? Can those technologies deliver effective communication? And unfortunately, what happens is sometimes you'll have technology available it's not available when it is widespread in the business world, but it's not available in certain sectors. So we want to advocate and fight for the having that accessibility available for everyone, consistent across all populations. So we would like to have one mandated experience for everyone. But there are some complexities that go involved with that. For CART, sometimes it's not involved with Zoom Live, or on Zoom Live there are some errors. When the transcriptions, you can ask for CART instead. It includes a link. Some staff or physicians aren't really knowledgeable about going to a link to connect to the CART services. So it's important that we educate them and make that transition easier and also more secure. And I would recommend that we think about the questions to ask. And one of those questions is not really the cost. First, we should think about the availability, if it's accessible for deaf and hard of hearing in all populations, and the equity, the equal access for example, for hearing people, maybe the ease of use is really, the deaf populations don't have the same experience. We're really fighting for that.
Okay, thanks. Really for the interpreter. Yeah, thank you, Dr. Mike. Suzy, I know that you had some experience in this area. Can you describe what type of inaccessible telehealth looks like to you?
Sure. Thanks, Matt. This is Suzy speaking. And I'll pick up on what Dr. Mike was just saying as well. You're right. There are many different possible ways to be communicating with your healthcare provider, but we're focusing now only on kind of video platforms, not audio only platforms, for two-way video platforms. In March of 2020, I got back home from Sun Valley, Idaho, which is one of the kind of hot spots for skiers, and had an outbreak of COVID. So having come home, I was exhibiting some symptoms of the coronavirus. I had a high fever, I had a sore throat, and I was very, very concerned and didn't want to go to a hospital and potentially expose other people. I also didn't want to be exposed, as I think at that time in March, many of us were in a state of panic because of the unknowns of the pandemic. We didn't really know the results at that time. So I wanted to stay home to the extent possible. So I have an app for the telehealth portal that I attempted to use for an unscheduled appointment, not for like a regularly scheduled appointment. It was like 8 o'clock at night and my fever was climbing. So I wanted to see what I could do to treat myself. So I went into my local app, but there were no instructions there about how to request an interpreter. So I decided to go into this waiting room, so to speak, and there were many doctors also that were attendant in there, and I was still on the lookout for a place where I could request an interpreter. And then eventually my call was taken by the first doctor, and then I said that I told him I was deaf and I'm trying to get an interpreter, but I don't see where, and seemed that there was no way to pull that in, particularly for an unscheduled appointment, to pull in an interpreter to that. So I struggled to communicate. I think that they told me to take 8 Advils every 2 or 3 hours, right? I mean, I did that regardless of whether that was exactly right, but I was still very concerned about my understanding of this doctor's instructions. So the next day, of course, I was still ill and at home. My fever went down a bit. I ended up going to the hospital after all. I tested negative, so it was just the flu, which was both good and bad. It's of course meaning it. I was still then able to catch COVID, but regardless, I reached out to my local telehealth director, the person who runs that system that uses the app, and we then worked together to try to develop a third-party plugin for their platform. It's a really large healthcare network in DC, so they luckily had the means for doing that. So basically, they developed a platform that has a front end with instructions on it that asks if you need an interpreter, instructs you where to click, and if there are any other accommodations you need, you should click elsewhere. So if you do need an interpreter, then you would click and be directed to a new video window, and the interpreter would arrive then within 1 to 2 minutes, very, very rapidly. They had established a contract with interpreters so that that whole platform would display the doctor, the interpreter, and then myself, as well as a chat box along the side. So we were able to have a discussion there and really communicate for unscheduled appointments. I was kind of a tester for that. I didn't have another emergency situation. I was helping them test it. It was very nice that they were able to establish that. So I asked them what they did, and they said they developed an organic solution using Bluestream and contracting with Amwell. So looking into it further, there are 4 large telehealth platform providers. There's Amwell, Teladoc, Doc on Demand, and MD Live. So it is important to consider how to reach out to them, because they need to have platforms that are that are made with different options, right? The options for captioning or interpreters, or even another video for a caregiver, right? If you have a person with a cognitive disability who needs a caregiver to participate, which is why this type of flexibility on the platform side is so important. It's something that the provider themselves may not be able to handle because they are provided with a product that they just receive, and that product needs to be made accessible. There's some technical things that have to go into that, but they need to coordinate for accessibility purposes. Another important aspect to that process is not just technical, it's also training of personnel. So my local provider explained that they then required every single telehealth provider to go through a 30 to 45-minute initial training session. And then another 20 minutes of testing. And on a monthly basis and a quarterly basis, they do test and training. So that way, all of their telehealth providers are very well versed on working with accommodations and pulling in interpreters, for example, on these unscheduled appointments. So that's where that was my experience. I wanted to share that kind of success story with you, but I also wanted to mention a few other concerns and considerations. I don't know whether that particular platform I'm talking about has captioning. I had asked and made sure that they should be aware of that. Whether those things are hearing aid compatible, I can't speak to. Whether they're screen reader compatible, I can't speak to. And that's where the vendors need to have their own checklist so that they have all of the different accommodations that they could need to provide in mind. So, certainly there's lots of work left to do, and I'm looking forward to everyone continuing to work together to make sure that happens.
Okay. Wow. Thank you, Suzy. Again, you're still on the hook. Okay. This is a follow-up question that I wanted to ask you. You've experienced the transition from inaccessibility telehealth to accessible telehealth. Can you describe the telehealth service that you currently use and what it looks like, and what do you find most helpful?
Yeah, I mean, that portal, I believe, meets my needs right now. I have seen a lot of different people using different portals and systems, and really we shouldn't be burdened with the obligation as individuals to tell people what we need. There should be instructions available on kind of the front page when you're going into the portal or the app. And it gives you the opportunity to request accommodations up front. You shouldn't have to go searching for it. And not only that, but for language as well. I've seen some now that have Spanish options as well. So the perfect portal, I think, would have a very well thought out, very well tested front end and well-trained personnel. And that's something that we still haven't quite seen. I've been asking around from other people's experience, and it has varied widely. Most people don't have the option for an unscheduled appointment to be interpreted or captioned on the spot. And that's something that I think should be accomplished.
Okay. Thank you, Suzy. So this next follow-up question is for Dr. McKee. What have you heard from your hearing non-signing colleagues regarding their experience trying to serve their deaf, hard of hearing, deaf-blind patient using telehealth? And what would help to improve their experience?
Thank you for that question. Again, this is Dr. Mike. So my hearing colleagues, one of the challenges that they've mentioned is that everything right now is new for everyone. There's a lot of changes happening. So a lot of people are sort of learning on the fly and at the same time trying to accommodate the needs of people through virtual health platforms. And that's not to say that we're not prioritizing accessibility, but education and training needs to happen.
2 o'clock.
Those things will happen as soon as possible. But now we have to open up different possibilities to connect with patients. And I've used a variety of approaches. Sometimes patients will be tech savvy. They can use the portal. And I emphasize to them that they may have an accessible platform, but maybe the patients aren't aware of what to do, of how to use it. So it's not accessible. The technology part, is still a struggle for them. For my hearing colleagues, one thing I've noticed, I'll sort of discourage you for this. So let's say a deaf patient tries to connect, or a physician tries to connect with a deaf patient, realizes they're a signer, and then they want to connect through VRS. Unfortunately, VRS interpreter may not be medically certified. They are community interpreter, meaning that they're not really a skilled medical qualified interpreter. So really, we need to reach out to qualified medical interpreters who have certification in that field and ensure that, and we encourage, there's more work to be done in that aspect, but some people do, they complain that it's hard to do that. VRS interpreter is ready, they can be contacted immediately, but I really try to explain to them that they're not medically certified. There's also, video is rich in data as opposed to a call. So suppose we reach out to a patient, we can see their background, we can see their home environment, we can see their presentation. Are they struggling are they having shortness of breath? Through a phone, a VRS, all of that is lost. All of that visual input is lost. There's no information that we can glean from what we're seeing from the patient. So that's not actually equally accessible. And that's a risky approach too. There are risks. Explaining medical terminology to the interpreter, their interpretation may be incorrect. So sometimes it can be easy so relay is easy to try to reach out to initially, but really there can be communication breakdowns when trying to use that. And speaking of, we have CART here available. So let's say there's a link, there's a separate Zoom link for CART, and they'll ask you to go to that Zoom link. Sometimes that isn't very efficient or smooth. So that's something that needs to be worked on. Live is new. Used to not be allowed because live captioning was replete with errors in the past. Interestingly, the hard of hearing community really wanted live captioning included. That was something they advocated for, but there's limited options when trying to set up CART and live captioning. So there's pros and cons to the approach, and it's a different world out there. And we're not blaming, but we want people to be creative and find different ways and strategies to really help them to ensure that everyone feels comfortable with the technology. And this is, from here on out, this is going to be a new world, what we're using. So we want to have clear training, make sure that there's a standard. And so like Suzy mentioned, there will be trainings required, the 45-minute trainings. Right now, there are no trainings for doctors that I'm familiar with. Some people may be familiar with the technologies, maybe younger physicians, maybe more tech savvy as opposed to more seasoned physicians. So it's unfortunately that can impact the patient experience. And sometimes deaf and hard of hearing patients, they know that COVID, the pandemic, is very stressful for physicians. They tend to sort of just accept what's given to them. And I would encourage them to speak up and really make sure that equal access is on the same footing with the hearing community.
Awesome. All right, thank you, Dr. McKee. All right, and so the next question that I have is for who should be responsible for ensuring that telehealth services are accessible? And is it doctors, or is it the technology company that develop the platforms, or some combination of both?
I would say it's both. And part of it is a legal answer, and part of it is that they simply should do it for a variety of reasons. The legal answer is that doctors and providers need to accommodate their patients for whatever the accommodation they may need, whether it is for a disability or a language barrier. That is required by law. And for those who have not seen it, Lisa's been putting some great resources in the chat that reference some of those guidances and laws as well. So they're required to make that accommodation. And as also pointed out, it's effective accommodation. It's not just simply, I made something available to meet their needs. It needs to work for that particular patient. So there's the legal responsibility there on the provider. So just because you're using telehealth, it doesn't mean suddenly all of your legal responsibilities go away. You still have the responsibilities to patients for a disability or a language barrier. You still have to abide by HIPAA and privacy. All those still apply. You just have to maybe take a different approach in order to meet your responsibility. Now, for the telehealth industry, they do not have a legal responsibility, but there's a variety of reasons why they should make these accommodations, these options available for providers to use. Because simply the providers have to have something, they need to use it. So it makes, I think, really great business sense if you're the only one that says, only company that has like all of these options. If I'm a provider and I have patients who need some type of accommodation, and there's like one vendor out there who has like all those accommodations that meet the needs that I have, and nobody else does, I'm probably going to go to that vendor. So it makes really good business sense for these technology companies just to make those options available, to develop those options. It's also the right thing to do. I mean, people with a disability are the same as everybody else. They're going to have healthcare needs. So why aren't you going to like make those options available or develop them? I think part of the problem before the pandemic was that telehealth was such a niche area, so small, it wasn't utilized so widely that there probably wasn't that pressure to like really make those accommodations or to develop them. So for example, I'm not saying all providers were doing this, but you may have had a provider who, if they had a deaf patient and they had like a telehealth option, they probably said to the deaf patient, well, why don't you come and see me in person? That way, you know, they can provide the accommodations that they may need as opposed to doing it via telehealth. So they never developed maybe like those protocols through their telehealth platform there. But then COVID-19 hits. Everybody needs healthcare services at this point, and everybody is turning towards telehealth. So you had that gap during the pandemic where those technology needs were not developed. And maybe some of that training, again, that Dr. Mike and Suzy touched upon for the providers weren't there. So they didn't know how to accommodate, how to like, you know, work with those particular patients via telehealth, even though now during the pandemic, they needed to do that. So I think the responsibility is on both. Legally, providers aren't going to get out of it. That's on them. But also the industry needs to make sure that they have those options that are available for the providers and for the patients to be able to access.
Okay, wonderful. Thank you, Mi. So before we go to questions and answers, you know, I have a couple more questions I wanted to ask before we go ahead into QA. I want to make sure that we have enough time for Q&A. But this question is for Lisa. Lisa, with all respect due to telehealth, describe your role at the administration for community living, and from your perspective, what do you think are the biggest barriers to making telehealth fully accessible?
Sure. Hi again, this is Lisa. So first of all, like I explained previously, I work for the Association for Community Living, the ACL, or Administration for Community Living, which is under the ACA. So, which we want disabled people to live with it, who are living within their communities, also more elderly adults. And so our approach is one of the biggest activities is grant. So the grantees of ACL for different services that are available out in the community from different organizations, nonprofits, and many of those you're probably familiar with. That would include Center for Independent Living, Assistive Technologies. Those programs, typically you have a piece of loaner technology or you get an assistive device. And I remember quite a long time ago, I received a TTY from an assistive technologies program. I'm sure things are very different now. Also, Share and Advocacy Center, which is a legal type of agency, which is available in each state and territory. We also fund state units on aging, who are working with older adults to get related services. There's one more I wanted to mention. Really, there's quite a few. There's quite an exhaustive list of organizations out there in the community that work with people with disabilities and elderly adults. And I just want to add that we also fund what's called RERC. I believe Bobby mentioned Gallaudet RERC, which is Rehabilitation, Engineering. The third R, I believe, is Research Center, the RERC. So there's quite a few different grants out there. And I want to specifically talk about the assistive technology program, because many of the questions we receive about assistive technology relate to telehealth, and I've noticed that in this conference. Assistive technology programs are doing some really wonderful things. They're using some funding specifically FCC CARES funding for telehealth, and that's used to provide hotspots or other types of telehealth equipment for the community. So I really want to encourage everyone to reach out to your state assistive technology program or your territory's assistive technology program, and I can include a link where you can find how to contact those programs, how to reach out to them. You can be involved in demonstrations of equipment. They have loan programs where you can borrow assistive technology devices, but it would depend on their policies. So really, I want you to interact with AT device centers and just be aware of the information of everything that's out there that's to support telehealth. And you can contact the Center for Independent Living. That would be for people with disabilities, and your area agency for the elderly. And so you can get a referral for the type of organization. And I strongly recommend that you reach out to one of those. If you have any questions about telehealth, I would encourage you to do that. And I want to circle back to an answer that one of our panelists, they talked about working with states. I want to encourage people to work with different state organizations or agencies that are receiving some of our grant funding. They are very engaged with the community. Also, really, they want to ensure that people in the community have services they need to live independently, and on the state level or for assisted living. So on the state level, reach out to them and better understand how they make policy decisions. My role in the ACL, I work in a very small office, which is the Office of Policy Analysis and Development, the OPAD, and we review many policies. This is from payment rules and regulations to civil rights types of documentation, notice rules making, website design. We do reach out, we look for the community and see what they need, what that community's demographics are, what is the research showing that's out there. ACL is the research that ACL is funding, what is the community saying? And that feedback we want to apply and modify our approach and the policies we're developing. And not all of our changes are accepted, just to be clear. So that's generally my role in the ACL. And like Suzy mentioned previously, I worked on and actually led an interagency federal partnership with Accessible Tele-Health. That group, there was many different federal agencies, including the FCC was involved, HRSA, which is the Health Resources and Services Administration, HHS Office of Civil Rights, the Department of Justice. So we really all came together. We talked about, okay, what can we do to move forward with what's making telehealth accessible? What is the next step? And those discussions took place. We also wanted to think about our goals and our vision for educating telehealth providers themselves. So Mai just commented that she was working with HRSA, and we've engaged with HRSA, Health Resource Services Administration. So we're trying to do a lot more outreach to the providers themselves and remind them of their civil rights obligations. So one thing we did, this was last year, the Department of Justice and Dr. Mike as well. He was part of a group that was presenting at a telehealth conference last year. It was wonderful. This was a coordinated effort from quite a few federal agencies and also telehealth resource centers. It was a great project, and we try to find different ways to continue doing those sorts of things. And I just want to add the last part just before I wrap up. Last week was very exciting. ACL joined with the Office of Civil Rights. We presented to the Interagency Policy Committee for the Executive Office of the President in the White House. So we presented what the community is saying about accessible telehealth. What have we seen that the community needs from accessible telehealth? And that brings me to my last point. The biggest point that we discussed at the White House presentation was that is for standardized telehealth accessibility. And this was from feedback in the community. And with that, I'll close and turn the floor over to someone else.
Okay. Thank you, Lisa. Suzy, did you have a question and then you wanted to turn it over to Mike?
Yeah, I wanted to add to what Lisa said. This is Suzy speaking. Lisa explained how the states have been working on accessible telehealth services and platforms to encourage that. Consumers can also advocate for that as well. I want to drive home that the Deaf and Hard of Hearing Consumer Action Network, DHHCAN, has a white paper on telehealth accessibility. So it is really important that consumers are aware of that. That's a possible tool for your use in your states, providing that as a patient, as an individual, or as an organization, Commissions for Deaf or Hard of Hearing, any number of organizations that you should go to speak with, including your local providers, to advocate for what you need for telehealth access. So there's already a tool that's written and it's out there, so you don't have to reinvent the wheel. So that's one quick thing I wanted to add in terms of resource. I don't have a link. I will look for that while others are talking.
Okay, thank you, Suzy. Mike, did you wanted to add anything else? Yeah, go ahead, Mike.
Yes. Yeah, this is Mike here. So another important thing for all of you to recognize and know is that right now, there are different options open and available. So we have telehealth. So there's some people that mentioned audio. So those phone visits, also the video visits, and sometimes they can be both audio and video. But right now, the reimbursements, meaning if you're submitting something through insurance and then you get paid from a doctor's for the services, right now that's open, which means it could be phone or video. Regardless, both are the same. And we suspect that later on that will change, which means they see phone consultations as not as equivalent. So they're going to reimburse less. So it's important for all of you to fight this, because what I suspect will happen is that a deaf person may have a conflicted, may have a struggle, and they may use VRS and they count that as a phone visit, but there's a potential risk for reimbursement there. So we need to fight to make sure that it's counted the same. We need to continue to have different available options too. And sometimes with the video, there's not any accessibility. So we understand that. Sometimes it requires to be in person, which is fine, but we need to make sure there's equivalent accessibility. If someone's sick, they want to come in, or maybe they're afraid, we want to make sure that we are able to support them to have an in-person visit to. And hopefully CMS will continue to reimburse that equivalent rate for in-person and plus video and phone visits. So that way people have different options. And again, the point is making things accessibility and to make sure that we consider all of those things too. May, did you raise your hand?
Yes, thank you. Since we're talking about what actions you might be able to take on the state level, I want to say, to just tag on to what Dr. Mike was saying, it's very important to act now because decisions are being made now. And there is an increased interest in making sure there aren't disparities between communities. But I think for a lot of policymakers, they're thinking more of people of different ethnicities or of income, and they may not necessarily be thinking of people with disabilities as a community. Not all policymakers, but I do wonder in some of the conversations that I've heard, it's like it goes beyond just race and income. There's like other people such as age, disabilities, etc., that may need accommodations as well. So Mike brought up a very important point about the audio only. That is one thing that we're not quite certain is going to stick around. And if it is something that is needed by the deaf and hard of hearing community, that access, or another community with a disability, they need to make their voices heard. Now, how do you go about doing that? The first stop is always talk to your state representative, but there are in a lot of states groups that are coming together to push telehealth policy. I'm based in California. There's a California Telehealth Policy Coalition that CCHP convenes. There are similar things going on in other states, but if you're not quite sure where to look, I suggest you reach out to the telehealth resource centers. There are 14 of them. CCHP is the one on policy it's a national resource center. There's a national resource center on technology, but there are 12 regional resource centers, and they cover specific states, and they have more of a ear to the ground on what's going on in their states. So they'll be able to direct you to folks who are very invested in like pushing these telehealth policies. Community health centers in particular have been very active during this time in ensuring telehealth policies stick around. So you might want to reach out to your local community health center or their association that represents them in their state. So they're usually called primary care associations. So they might say something like the California Primary Care Association. That's how you can kind of find them.
Okay, wonderful. This is all great information. And I believe I have the very last question for the audience. This is the question from Mai. I understand that your organization is for the Centers of Connected Health Policy, is one of the 14, telehealth resource centers. Please describe, these centers and what your organization role is and what some of the resources and tools that the telehealth resource centers offer.
Yeah, so besides like what I just mentioned a moment ago, that connection to like local groups that might be working on telehealth and telehealth policies. So what the resource centers do, the 12 regional ones, they provide program operational level assistance to providers who are interested in starting a telehealth program. So when the pandemic hit, they were helping a lot of providers just get telehealth up and running. And one of the things that we've started to do a lot more is to make sure that they cover all the range of needs. The education tools cover all the range of needs that people may have. So not only like language accommodations, but accommodations for people with disabilities, accommodations for people in urban and rural areas. Because even before the pandemic, most of our charge from our federal funding was kind of more concentrated in like the rural regions for like community health centers or hospitals, and not necessarily the broad range of folks that we have to help now, which are hospitals or individuals and people in urban areas as well. So some of the things that we've developed have been fact sheets, and some fact sheets that are aimed at the consumer, the patient themselves, just informing them on what telehealth is, and also how to talk to your provider about telehealth. So a lot of this is really communications and letting you know, like, what are the questions you should be asking them. If you need an accommodation and you're doing like a telehealth visit, ask for that accommodation, and the provider should be able to provide that with you. And when we're talking to providers saying you may have a patient who may need an accommodation, perhaps they are hard of hearing, what are you going to do? Look for a technology platform that has those accommodations. So we try to like set up both the patient / consumer and the providers up to like try to address any need that comes through their door, make sure that, you know, they're aware of all of their obligations. Now, that being said, none of us are technically, I'm a lawyer. I don't give legal advice. I'm not supposed to. So we're not giving out legal advice. We're just giving them information to make them aware that these are things that they're going to run into and questions that they're going to run into. So I really do encourage you, if you have questions regarding telehealth, to first reach out to those regional telehealth resource centers for your answers. We all are in communications with each other. So if they have a question that they can't answer, they usually send it to the other 13. And then one of us usually like finds the answer for somebody if we don't know it already.
Okay, awesome. Thank you, Mike. Really good information. And this next question is for Suzy. Suzy, you can throw away your patient hat and put on your FCC hat. The last question I wanted to ask you was, what is the FCC doing to support the telehealth providers and, you know, during the pandemic and future purposes?
Hi, this is Suzy, and I see we've only got 3 minutes remaining, so I will make this just 1 minute so that everyone else can have an opportunity to say something as well. But yes, the Federal Communications Commission has been taking a lot of action to distribute funds to healthcare providers to support their ability to provide remote services. It really is about things like broadband and equipment and so forth. So we've distributed, I think it's about $650 million thanks to Congress, congressional appropriation. And our language for those providers who are receiving funds does emphasize that you must comply with the ADA and other applicable federal laws, of course, but we specifically call out the ADA there as a reminder to them because the FCC specifically has limited jurisdiction there. So we appreciate HHS's leadership in the accessibility space for telehealth. So with that, I just want to thank everybody for all of your time, for being here with us. Hopefully we'll be able to continue to see this space evolve rapidly. Of course, you know, as everyone has said, it is very timely, it is very important, and it's never too soon to communicate with your local providers to try to affect some change in accessibility. If like 911, you don't want to have to worry about it until you have to make a call, but you want to make sure that it's available and accessible at that time. And the same thing goes for telehealth, I think, for things like overnights or urgent calls that you're trying to make. Yeah, Mike?
I want to add one more comment. I want to encourage people to start thinking about the time that it's going to take for innovation, the time for change, and really the first time in history, there's been so many doctors and staff and everybody are just trying to figure out what's going on. And now we have to rethink all of this. So I think we need to take this opportunity and this time just to encourage all of you to think about the innovation and accessibility and the diversity that's out there, and make sure that your voices are heard and that you're seen. And it's most important to take this opportunity. There's so many, this is the biggest change I've seen thus far. And we have to make sure that we keep moving forward. We push everyone, we encourage everyone to go so we can all have a seat at the table too, so that the future will be good for us.
Okay. Wow. I wish we were not out of time. I would love to hear from the panel, from the audience, you know, and this has been a very great discussion. It's needed. We need to talk about these things, you know, that's why TDI is here. And, you know, again, you know, I want to thank the panel for, you know, being here and talking on the sensitive topic of telehealth and the good stuff and the bad stuff. You know, we need to address that all as one. And so again, I want to thank you for all your time and your participation and your efforts. So again, thank you.
Yep, thank you. Thank you, everybody.
Bye-bye.
Bye.
Bye.